There we go. I don't know why. It suddenly worked. So again, that was just a great, very comprehensive review, and so I'll breeze over the things that I think are redundant and try and add some commentary where it's useful. So this is again a slide to emphasize the importance of doing something about vein grafts. If we're going to use vein grafts, then we need to do something to improve their patency. Now we can look at various different studies, pick which study graft patency we want to believe. Prevent 4, I can promise you, is the one that the cardiologists all quote. I'm sorry?
The one the cardiologists all quote.
That's so we have to be careful what we put in the literature. But regardless, clearly vein graft patency doesn't measure up to arterial graft patency. So if we're going to use them, we ought to do what we can to try and improve the situation. And of course, this is part of the problem, at least in the chronic phase. So ACC/AHA guidelines. I don't need to repeat this. Here's my mumbo jumbo slide, which for me the utility of it is just to see that there are a couple of different targets. Of course, aspirin directly inhibiting COX-1, but also the P2Y12 antagonist, which is clopidogrel and such. And the latest, you read the cardiologic literature and their mouths are watering over the next platelet inhibiting agent that they're going to create, because there's still some ischemic events that occur, because there's still some platelet activity. They want to turn us all into jellyfish or something here. So that's going to be the latest group is this group up in the corner, the PAR1 antagonist. So buckle your seatbelts. So a couple of the trials, again, that address the issue of clopidogrel. I had a lot of discussions with Bernie Gersh when I was in Rochester about preoperative clopidogrel and whether or not it impacted outcomes. It's interesting that oftentimes, again, the devil's in the details. If you just read the abstract to these articles in the cardiologic literature, it'll say preoperative clopidogrel did not have an impact on bleeding, but if you read the fine print, you discover that most of the patients were kept in-house for 5 days, letting the stuff wear off, which certainly is an issue for us as we're leaned on constantly to reduce length of stay. And yet you'll hear from the cardiologic group, oh, go ahead, come on, such and such a study didn't show any impact of preoperative clopidogrel. If, however, you look at the impact of preoperative plavix on the percent of patients who required a transfusion, there's a pretty nice curve that explains. I had not seen this curve before I had the opportunity to try and look up some data for this talk that really substantiates the notion of waiting 4 or 5 days to let the plavix wear off a bit. What about postoperative clopidogrel? This is the study from Canada about that randomized study of aspirin and clopidogrel versus aspirin alone, and it actually did not have a positive impact. You can see the percent of occluded grafts all told. Lima, no impact at all. Rima, the saphenous vein occlusion rates were about 6.5%. Radial artery occlusion rate was a little alarming in this study, but it's a very small number of grafts. But I think that this reinforces the notion that at this point in time, I'm not aware of data that actually support the use of postoperative plavix in terms of improving graft patency. This is an old one that's almost of historic interest only, but I found it in one of the talks I gave some years ago, just in case you have questions about whether or not warfarin is helpful. I do use warfarin when I do an endarterectomy, but warfarin doesn't improve graft patency. Certainly when I was a resident, there were some staff surgeons that would advocate using warfarin for people that had particularly bad distal vessels and so on. Statins, you've already seen this figure. I think an additional point that I would make is that it shows an improvement in graft patency to an LDL to 70, but no additional benefit by driving the LDL below 70. We ought to target 70, though. I threw in something about beta blockers. I know that doesn't address graft patency, but it is pharmacotherapy of the patient, and we are trying to take care of patients, not just grafts. And it brings up one of the peculiar, perhaps unintended consequences of these practices when they become practice measures. We are constantly subject to government assessment of our practice measures. I'm not sure how much you are in terms of preoperative beta blocker use, and one of the practices that occurs is to just administer just a milligram of esmolol immediately before induction if the patient hasn't had their beta blocker. So it makes you wonder about this, pursuing the metric and not the care of the patient. It's like pursuing the metric of an on-time airplane departure and sacrificing service at the cost of that. But just to conclude again, the notion that vein graft patency is a problem, and I'm delighted that there's been so much discussion here today about arterial grafts and different approaches to arterial grafts, and I hope that if there is one thing that you actually do differently, if Andy's right that this kind of a forum can actually make people change their minds because of the dialogue, it's the importance of using arterial grafts, because vein grafts, even with modern pharmacotherapy, don't measure up to arterial grafts. Thanks.